It is difficult to define asthma, but at this moment in time, it's accepted that asthma is a disease in which the air pipes in the lung are inflamed. Maybe I need to explain what inflammation is. When the body is injured by something, there is a reaction, and that reaction is called inflammation. The easiest way of thinking and understanding inflammation is to imagine a burn. So if some part of the skin is burned by anything, it becomes red, swollen, we'll have small wounds or big wounds, and it'll be oozing fluid. That's inflammation. So in the air pipes of people with asthma, there is inflammation. The air pipe is raw. Consequence to that inflammation, people then experience symptoms of cough, shortness of breath, wheezing, and feeling tight in the chest. These symptoms may be there all the time, that is called persistent asthma, or may come and go. And usually, for most people, those symptoms tend to be triggered by specific factors. When we then check how the lungs of these individuals are performing, we notice that there is variation in the way the lung is functioning. So that's how asthma is defined. At this moment, it is estimated that world over, there are slightly less than 300 million people, or just about 300 million people who suffer this disease, asthma. The disease is much more commoner collectively in low and middle income countries like Kenya. In our own country, Kenya here, we don't have very robust data on how much asthma we have. But based on studies that were done in this country many years ago, and looking at the population structure and distribution between cities and rural areas, we estimate that up to 4 to 5 million Kenyans in this country may have asthma. Typically, people with asthma will present with 4 key symptoms. They tend to cough, they have shortness of breath, they have a feeling of tightness in the chest, and they wheeze. These symptoms tend to be worse in the morning and tend to be worse at night. And these symptoms also tend to be associated with specific trigger factors. In our setting, those trigger factors include environmental factors, like, for example, when it's cold or dusty, includes exposures to pollens and grasses, pollens from trees and grasses, and also sometimes exposure to animals, including large animals and small animals. And these symptoms then should lead a doctor. If one consults a doctor with these symptoms, the doctor should be thinking about asthma. And if the doctor has all the tools that are required for diagnosing asthma, and especially a tool that is called a spirometer. A spirometer measures the volumes of air that come out of one's lung when they forcibly remove that air. And if you have a spirometer is used to confirm the diagnosis of asthma. In the absence of a spirometer, there's a much more simpler tool that is called a peak expiratory flow meter. And a peak expiratory flow meter will measure the flow, or in simple terms, the speed with which you can bring air out of the lungs when you blow that air out of your lung. And certain changes in the volumes of air that come out, or the speed with which you can bring air out of the lungs, will tell the doctor or the clinician that this individual has asthma. In the absence of tools, clinicians should still be able to make a diagnosis of asthma. In the person who presents with typical symptoms, in the absence of spirometry or peak expiratory flow, you make a clinical diagnosis. We call it a syndromic approach to the diagnosis of asthma. So in that individual with typical symptoms, The absence of a spirometer or a peak expiratory flow meter should not be a complete barrier to the diagnosis of asthma. However, the presence of these tools increases the precision with which the diagnosis of asthma is made.
Asthma occurs in about 13% of teenagers from Kenyan studies and 11% of children who are in primary school. So 1 out of every 10 children has asthma. It's fairly common in Kenya. This is Kenya statistics. It's a bit more common in children living in the cities than in those who are living in rural settings. And this is probably because in the city the air is not as clean. You have much more pollution and much more overcrowding in homes. Yeah, but the difference is not too big, maybe a 2-3% difference between those who are living in the cities and those who are living in the rural area. So asthma is quite common in children and in teenagers. You know that your child has asthma if they keep getting chest problems. And how do you know what type of chest problems? They keep having a problem with coughing, congestion in their chest, or they say, my chest is blocked, I can't breathe very well. Or sometimes you can hear wheezing, a whistling sound. Whee, whee. Now, these are symptoms often, they're the same as when you get a common cold or a throat infection. So how will you know that these symptoms that your child has are likely due to asthma and not due to just having a common cold? With asthma, these symptoms tend to be worse at night. They come at night like 2 a.m. when the air gets very cold because their lung doesn't like the cold air. And towards morning, they continue to have this coughing, shortness of breath. And then as the day gets warm, then the symptoms disappear. And you wonder, was this the same child who was so sick at night, but now they're completely fine? A common cold or a throat infection doesn't behave like that. The other thing is you might also notice that for some children, this chest gets disturbed by things in the air that their chest doesn't like. Now, common things are pollen, like if they're playing in a place where there's very long grass, or they've just cut the grass, there's a lot of pollen in the air, or a lot of flowers, then when they're in that place, then you hear them having these symptoms. So it's triggered by pollen. For other children, it's triggered by running a lot, exercise. Actually, it's quite common with children. So you'll notice that my child runs a lot, then after some time, they start to cough and get congested in their chest. So the other thing is that it tends to recur during the cold seasons or when there's a change of season, and it lasts for longer than expected. So if your child has these recurrent or persisting symptoms, it's most likely that they have asthma. Now, most diseases are treated by giving syrups or tablets by mouth or by injections. Now, asthma is a bit unique because the problem is only in the chest. And so nowadays we have really wonderful drugs that can be given only into the chest. Now, if you give the asthma medicine, as we used to do many years ago, the syrup, you'd have to give 100 times more medicine in 1 teaspoonful. The medicine will get into the stomach and it will take 1 hour to go around and finally get its way to the lung. It takes a long time for it to help the child. But now we have much better drugs which are in a spray form. This is what we call an inhaler and spacer, and inside it has the medicine in a bottle. So with children, what you do is you shake the medicine, remove the cover, and when you spray like that, the medicine can go into the child. Now with adults, they can actually spray directly in their mouth, but children can't do it very well because it needs you to coordinate. So with children, we help them to breathe the medicine comfortably using this gadget, which we call a spacer, okay? So we spray the medicine, So you place this into here, and you spray the medicine into here. And then this will be placed on my baby's face, making sure that there are no gaps, because if there's gaps, some of the medicine will get lost. So you get the right size, and then you put it there, and you spray like this. And then the child just breathes normally, and you count to 10 breaths. By the time they've taken 10 breaths, all the medicine, the spray, will have gone nicely into their lungs, and it starts working immediately. Within 60 seconds of breathing this medicine, if your child is struggling to breathe, it's like magic. The lungs start to open up, and they start coughing less, and they're able to get air into their lungs, and then the asthma attack gets down. So usually you'll give, that's like what we call one puff. Depending on how bad it is, you might give a second puff of the medicine, and you count, they breathe 10 times. These are for children under 5 years. Children older than 5 years can often use this gadget, and you can spray it. You can spray it direct. All the children and even teenagers don't like carrying things like this. So for all the children, I'll just use the baby as an example. They can put it directly in their mouth, and you spray, and then the child takes a deep breath. If they're older, they can actually take a deep breath and hold it for up to 5 seconds, and the medicine will have gone nicely deep into the lungs, and the asthma attack, the lungs start to open up. The pipes that are blocked and tight like this, they start to open up. So for older children, they can just use this spacer. Now, this spacer is really good because a much higher amount of the medicine gets into the lungs than if you just spray directly. Yeah. So we have different types of medicines for children with asthma. They work very well. One medicine is for taking every day. And what it does, it gets in there and it calms down their lungs, stops it from overreacting to running, overreacting to things in the air. And it allows a child to play their football without getting their asthma attack. It allows them to have a normal life without getting sick all the time. So that's what we call a controller medicine. It controls the asthma. It tells the lungs, calm down, don't overreact to these things in the air. And then we have a second type, which is like a salbutamol, which they only use when they get an asthma attack. And that one they will just use for a few days until the lungs open up, and they'll be fine. So that's medicine for asthma. It really works well. Your child will be healthy, enjoy a normal life, and they'll grow up with good lungs. Thank you. Some children, as they grow older, the asthma symptoms get less. Asthma is, for most children, is an allergic chest problem. And as you know, with allergies are usually part of you, and they'll be with you for most of your life. Now, children who have allergic asthma, or theirs is a chest allergy, often it is worse in the first 5 years of life, and then it gets better. But when they get to teenage years, for some of them, it comes back, okay? Something to do with the hormones of puberty. For other children, they will have their asthma symptoms throughout there until they grow up. And for a few other children, they will have only the symptoms in the first few years of life. And then for some reason, as they grow older, their chest gets used to these things in the air and the asthma disappears. So it's different for every child. For those who have allergic asthma, it's just very important to know that they do have it and to watch out for the symptoms. So they might have problems in the first 5 years, and then it disappears. And then when they're 14 years, suddenly, when they're playing sports, they get sick, they start to have an asthma attack. Just always be aware that there's possibly a risk of my child getting that attack. But most of them can be healthy with asthma medication.
The pharmacist is a very important healthcare provider in asthma management. He is able to provide education to the patient or the client. He's also able to assess correct inhaler use technique and also train patients and clients on how to use inhalers. Importantly, he's also able to provide information about the medicines that these clients are taking and also be able to monitor side effects and communicate effectively the side effects that the clients need to watch out for. Patients have a personal responsibility while collecting medicines from a pharmacy, importantly when it comes to asthma management, in the sense that they need to know the medications they are taking that have been prescribed. They need to fully understand how to take them. When they have inhalers as part of their medications, then they need also to understand how to use them correctly while the pharmacist is training them. They also need to ensure that they are not requesting over-the-counter medications and switching medications during asthma for asthma management without consultation of the pharmacist or their primary caregiver, the medical doctor.
Asthma control is a concept about how well a patient's symptoms, frequency and severity is reduced with treatment. It's about reducing the frequency of their reliance on their reliever treatments. Reliever treatments are those that patients take to alleviate the symptoms of asthma as and when they happen. It's about reducing disability from the symptoms of asthma day in, day out. You can actually measure, quantify and record asthma control using validated tools, for instance, the asthma control test or the asthma control questionnaire. And over time, during clinic, you can trend the questionnaire and see that and document that actually the patient has better control over time. The overarching principle in asthma management is patient empowerment. So patient empowerment is about the patient understanding their disease and understanding their treatments and understanding what to do when they're in trouble. The first thing is about prevention. Asthma patients describe very definite triggers that bring on their symptoms. For instance, it could be fine dust, it could be flour, it could be dander from pets, it could be exposure to cold drinks or to cold weather. It could be very strong fragrances. Patients know what their triggers are and they are advised to avoid them. That's the key principle in managing asthma. Drug treatment entails two concepts. The first concept is regular treatment. This is really, really important in reducing the disease process inside the airways in the lungs, and it needs to be taken on a daily basis. And this invariably contains a steroid-based treatment. The most commonly used drug delivery systems are inhalers. There are different types, and these are taken to deliver the drugs to control asthma. When patients experience symptoms which arise due to exposure to triggers, for instance, they need to take reliever medication. These invariably contain bronchodilators or medication designed to open up the airways. There are those that act quickly, but for a short duration, and they're called short-acting beta agonists, or those are short-acting bronchodilators. Some actually alludes to this. There are those that actually work over a long time, and there are those that act rapidly, and the effect persists over time. It is important that asthmatics learn when to take their SABA medication, and that when they take them on a regular basis, on a frequent basis, it usually denotes poor control, as we alluded to earlier. And that usually necessitates them to visit their healthcare practitioner for better control. SABA over-reliance is a concept which we have described in many patients who do not usually perceive a ready benefit when they take their medication, their maintenance medication on a daily basis. They don't perceive any benefit from it, much as it is actually quite important to them. And inadvertently, they stop using this medication. But then they soon experience the symptoms when they are exposed to the triggers. And as a result, they use their rescue medications, which could be a SABA medication. And they end up using nothing but their SABA medications on an emergency basis to relieve their symptoms. And there's good evidence that patients who do not use steroid-based maintenance treatment and only rely on their reliever SABA medications actually have worse outcome. They have poor control of their asthma. They end up being admitted into hospital. They end up requiring critical care admission and care. And they end up actually dying from multiple reasons, including heart attacks and poor asthma control. So SABA over-reliance is an important concept that we all need to avoid. I think the key take-home message is however well a patient adheres to their medication, an increased need for reliever medication is a trigger for them to know that their asthma control is not very good and that they require to go and see their healthcare providers to have better control. So there are many myths or false beliefs that lots of people hold. So for instance, there is a myth that asthma is a familial disease, or that one needs to have had it from childhood, or that it comes only in childhood and disappears over time during adulthood. Whereas asthma is a condition that doesn't really disappear. There is no cure for it. It can happen in adulthood, and it's a condition that needs treatment for people to overcome it. There's also a myth that asthma is not a serious disease, whereas we know that without treatment, people do die from asthma. About 10 people every day die from asthma when it's not well controlled. And then there are myths about inhalers, which are devices used to treat asthma. So a lot of people think that by the time they're being given inhalers, they have a very severe disease. It's a precursor to death. Whereas inhalers are actually very simple devices. They're very smart drug delivery devices. They deliver very minute doses of steroids and other medication that we need right where they're needed in the airway. They're carried by the breath that we take right to where the problem is. So a lot of people think that inhalers are actually a precursor to death, whereas there are really, really good ways of delivering drug treatment. There are myths related to reliance on treatment, that if you are put on treatment for asthma, then it means you're going to be addicted to it, and that's the end of your life. You'll have to live on them. Whereas the evidence actually shows that people who use their treatment well end up needing less and less and less of it over time. So the better the control, the better the treatment, the less the reliance on it.
Health system approach to asthma care now within the Ministry of Health is one. Asthma care is domiciled within the TB program under the banner of lung health, and what the program does for this is to ensure that policy development has been done. We also have to develop training materials, guidelines for healthcare workers, and of course at the end of the day then ensure that diagnosis of patients is done in facilities and given the right drugs for those patients. The gaps which requires to be addressed in asthma control, amongst them is of course one, talking about guidelines. We need to have our guidelines reviewed. 2, training of healthcare workers, and then 3, ensuring that also healthcare workers are trained on how to utilize asthma drugs. the government has equipped facilities with spirometers. Currently, we have 30 spirometers which have been distributed to all county referral hospitals. We are also procuring peak flow meters. And currently, and in this particular year, what the government is doing is to ensure that all facilities are equipped with spirometers, equipped with peak flow meters, so that then it makes it easier for clinicians to be able to make a diagnosis of asthma and, of course, be able to manage them well. And, of course, and another aspect, again, is looking at the training of those particular officers to be able to operate those particular equipment which has been procured by government. We have training packages for healthcare workers for asthma, which was developed in 2018, and we currently require to be able to review them also to ensure that they are factoring in the new drugs which have come from that particular moment. I know quite a number of changes have taken place, so we need to update those training materials to be able to factor in inhalers and the new medicines for asthma, so that then healthcare workers are able to use the right regimens for their patients.
The challenges I face as an asthmatic patient, I always get difficulty in breathing, and it interferes with my health a lot. I get, even accessing, going to the hospital is becoming a problem to me. I find it walking is a problem. I can't breathe. Sometimes people run away from me. They don't understand what's happening. They don't know what first aid to give. Even my family, by the time we are all asthmatic, my children, so it compromises our health in all. Even as the place of work, it has been a problem because I can get an asthmatic attack. I'm attending to somebody, and it really cost me a lot getting the inhaler. As I'm using the inhaler, sometimes I don't have the money to buy the inhalers. So we'll request if we can be able to access the inhaler, even the affordability, they can bring it at a cheaper cost for us. And even for other patients, it is not easy to cope with asthma. But I've got the support from my team members, and even from where I am, we have gotten the support. But we'll request the government to help us access the medications and make them affordable for us, and give us even trainings on how we can cope, and even all the support from different areas on how they can support the asthmatic patients so that we are able to cope. Outside there are others who are suffering because they cannot afford, they don't know how to manage the asthma. We need proper people to teach us how we can do management of asthma, and even for the ones who do not have the knowledge, to be taught on managing of asthma by use of inhalers, regular medications. Like I have to take medications every day. It is very costly. I have to keep warm. It is very costly. I have to keep I have to make sure that I have to report to work despite me having the asthma. But I have just to take it positive that it is there. So the people who are outside there who are also having asthma, they need to know that asthma is real, but they can be managed. But we also need the support on how we can help us to manage asthma.